which blood supplies the posterior side of the heart, the back of the heart, and which blood supply for the heart for the anterior side of the heart. So there are three coronary arteries, the right coronary artery, the left coronary artery, and the circumflex, and you should know where those supply blood to. You talked specifically about the difference between hematocrit and hemoglobin. What association can you make with those two numbers?
Sorry, what was that?
What association can you make between hematocrit and hemoglobin? So if the hemoglobin's 15, like it should be, what's the hematocrit?
3 times.
3 times, so 45. If the hematocrit is 60, what's the hemoglobin?
20.
20. If the hematocrit is 10, what's the hemoglobin?
3.3.
3, exactly. So if the hemoglobin's 3, does that cause any concern?
Yeah.
It should. Absolutely.
Yeah.
Absolutely. So there is a relationship between hematocrit and hemoglobin. We use it frequently, especially in the newborn ICU. We won't do a hemoglobin because it takes a lot of blood, but we will do a hematocrit tube and spin it out and measure a hematocrit directly. Cells responsible for antibody production. In the blood, there are cells that prevent blood loss. Do you remember what they are?
Sorry, say that again?
Cells that prevent blood loss. Platelets. And what's the other one?
Platelets and
What if you have thrombocytopenia? What would that result in? Thrombocytopenia. So some of it is learning the language. Thrombocytopenia means low thrombocytes, and it would probably cause bruising. So it causes leak into the cells, and you get a bruise from thrombocytopenia. So thrombocytes and platelets help to prevent clots. Once oxygenated blood has supplied the heart tissue itself, there are specific structures that deliver deoxygenated blood from the heart back to the left atrium. What's the name of that structure?
Sorry, so
Deoxygenated blood back to the left atrium. So that's the oxygenated side, right?
Yeah.
There's a structure that delivers deoxygenated blood from the heart to the left atrium. Find out what that structure is. So it's heart. It's blood that supplies the heart through the coronary arteries, and then it comes back through a structure to the left atrium. So it's delivering deoxygenated blood back to the oxygenated side. You remember what we call that, first of all?
Pulmonary vein?
No, it's not the pulmonary vein.
Sinus.
We call it, yes, that's the one, dear. But it's called venous admixture when we put deoxygenated blood into the oxygenated side, and that's part of when we develop a shunt. So I wonder if we need to calculate a shunt again. We probably should.
Is that
Just made me think.
For a calculation we may need to know?
I'm thinking. It just jogged my memory. I'm thinking maybe we ought to review that.
Where's that
I think so too.
Okay. Distribution and regulation of arterial blood pressure. Distribution and regulation of arterial blood pressure.
Distribution and
We divided the cardiac output into 3 different in 3 specific ways. One is as preload. You remember? So find a definition for preload.
preload, loading.
Afterload.
Yeah,
A
afterload.
definition for afterload, and a definition for cardiac contractility.
Preload, afterload, and
So
sorry, what's the third one?
What's preload? Contractility is the third one. What's preload? Preload is the amount of blood that fills before it goes to the ventricle. Afterload is resistance by the pulmonary system and the systemic system. And contractility is how forcefully the muscles will contract. Definition of the volume of blood ejected from the ventricles per minute.
Definition of the volume of blood ejected per minute.
Yep. the amount of blood ejected per minute. We divided the lungs into 3 different zones: the apical segment, the middle, and the lower lobe. You should be able to recognize in a gravity-dependent lung,
Oh,
the arterial pressure is greater than the pulmonary pressure. So there's a table in the text that specifically looks at pressures from the alveoli to the pulmonary artery to the
Here.
pulmonary vein.
Page
Yes,
237.
exactly. 237 in the 3 zones of the lungs. Which one has the best gas exchange? Which zone, 1, 2, or 3, has best gas exchange? In which one?
3.
3 probably because it's filled with more blood, but the apical segment has better ventilation. Right, better ventilation overall, but best gas exchange is in zone 3. So I don't think I asked you specifically that question. I just wanted us to know that we get better distribution of blood and gaseous exchange in zone 3. Let's see. We talked about the idea of distension and radial traction in the alveolar vessels.
Sorry, for distension and what?
I'm just trying to think. That's a different term. Recruitment, I think, is the term that we used. So sometimes increased blood pressure recruits previously closed blood vessels. It recruits vessels, and they also distend. So recruitment and distension is an important piece to regulating blood pressure in those gas exchange units. Recruitment and distension. Simple definition of plasma without blood proteins. A definition of plasma without blood proteins.
Is that serum?
So usually we spin out all the red blood cells, and you've got serum up at the top. The forces that influence circulation of the blood. What's that called?
The what, sorry?
The forces that influence circulation of the blood. What do you think, Armando? Forces that
Osmotic?
influence circulation. So
Forces. What do you mean by forces?
the
Like
title
there's a
of
name
the
of the
title of
forces?
chapter 15 is called
Oh,
Hemodynamics. Okay.
Yeah.
Very good. The amount of blood circulated for each contraction of the heart relative to body surface area. Each contraction relative to body surface area. So if anything is relative to body surface area, we call that an index. So there's cardiac index,
Body surface area.
body surface. Each contraction per body surface area. Bless you. So that's a definition in the hemodynamic chapter.
Okay.
Systemic vascular resistance that looks at the afterload
Sorry, the
of
what?
the right and the left ventricle. Systemic vascular resistance would look at the afterload of the right ventricle, no, left ventricle. Pulmonary vascular resistance would reflect the afterload of the right ventricle. Another definition about cardiac index.
Okay.
How many molecules of oxygen is carried by a hemoglobin molecule?
I mean,
Sorry, will you say that again?
How many molecules of oxygen is carried by a hemoglobin molecule?
4.
The amount of oxygen physically dissolved in plasma. So I give you it's a definition. The amount of oxygen physically dissolved in plasma. Well, it's 0.003 times the PaO2, right? A definition that's reflected by 5 grams of reduced hemoglobin. 5 grams of reduced hemoglobin. What's that called? the text talks about 4 different kinds of hypoxemia. And this is, I didn't spend a lot of time on it. Venous admixture. So hypoxic hypoxemia, circulatory hypoxemia, anemic hypoxemia is low hemoglobin. And then they talk about cyanosis. Make sure you pay attention to those definitions. There's a question on P50, a left shift of the oxyhemoglobin dissociation curve. The amount of oxygen extracted by the tissues in 1 minute.
Sorry, say that last one.
The amount of oxygen extracted by the tissues in 1 minute. I give you a result of shunt. So if I say that a shunt's 20%, what does that mean? Or what conclusion can you draw if you know that a shunt's 20%?
What was, sorry, can you say that?
A percentage of shunt, what a shunt means or what a shunt
Like
represents. Or if you have a 20% shunt, what does that mean? Usually less than 10 is normal. We expect there's a little bit of a shunt. About up to 5% is normal. 10% is getting a little high. 10 to 20, definitely there's intrapulmonary deficiencies. Above 20 is serious, and above 30 is life-threatening. We should know what that means. Factors that shift the curve to the right. Presence of carbon monoxide in alveolar air. What happens?
Carbon monoxide?
Yeah, carbon monoxide in alveolar air. The difference between arterial and mixed venous oxygen content. Arterial, so that's A, venous, B, O2 content difference. And that's an oxygen study in the end of the book. AVO2 content difference. It's really just the difference between arterial and mixed venous content. We understand it to be 5 grams per cent, and the tissues need 5 grams per cent for normal metabolism. Each gram of oxygen. Another question on shunt. What did we understand pulmonary capillary wedge pressure to be? Remember that measurement? PCWP, pulmonary capillary wedge pressure. So remember, if we put that catheter into the pulmonary artery, we occlude the pulmonary artery. If there's no blood flow past that catheter, there's no resistance. And if there's no resistance past that catheter, that relates back to the left atrial pressure. So pulmonary capillary wedge pressure is essentially left atrial pressure. And we draw conclusions about the filling pressure of the left atrium from the pulmonary capillary wedge pressure. So make sure you review what pulmonary capillary wedge pressure is and how we understand it. Wedge is an important number for us to understand left atrial filling pressure. Primary function of thrombocytes. That one you shouldn't have any trouble. Pulmonary arteries. Question on pulmonary arteries. In the cardiovascular chapter, we talked about what the P wave represents, what the QRS represents, and what the T wave represents. So take a look at those carefully. What the P wave represents, what the QRS represents, and what the T wave represents. There's a video on YouTube about how a professor teaches atrial contraction and ventricular contraction. Have you seen this one where atrial contraction is this, ventricular contraction is this? So atrial contraction, ventricular contraction. then he does this. He'll do this a couple of times, then he'll do this. So that's atrial fib. And he'll do atrial Premature ventricular contractions.
Is it really?
We'll have to look at
That's hilarious. You should do that.
Yeah, you can do that.
Atrial contraction,
Like in the testing
ventricular
center.
contraction.
Sing a song.
He's an old guy about 90 that does this, but
Oh,
he's
wow.
teaching his students about the P wave, the QRS, and the T.
That's cool.
Remind me someday, I'll show that to you. Difference between hypoxia and hypoxemia. And a bonus question.
Which count?
Bonus question is something to calculate.
Shunt.
You shunt. You can give us which version it is. So we have to know all of them. Why she didn't give us one way? We have to know every single one of the ones that we're breaking down.
It's really just oxygen content, right? So if you know the barometric pressure, say at 760, you know the hemoglobin, well, on an ABG you'll get an arterial, you'll get a mixed, you'll get a pH, CO2, PO2, bicarb, saturation, hemoglobin, content, met, carboxy, and base excess.
Are you giving us all this info?
Yeah, I'll give you a blood gas. So if I give you a blood gas, you should be able to figure out a shunt. CCO2 minus CaO2
Divided by.
CCO2 minus
Yes.
CeO2
Here we go. buddy.
QS
We gotta
over
find those numbers.
QT.
Yeah, and then we have to find those numbers too.
So pH is 7.34.
What?
CO2 58, PO2 60, PO2 55, 31, bicarb 24, saturation 90, 76, hemoglobin 14, content, I'll have to figure that one out. Met hemoglobin 0, carboxy hemoglobin 0, is -5. So if I'm given an ABG, an arterial and a mixed venous, I should be able to figure capillary content is, I have to do hemoglobin of 14 times 1.34 times, we understand the saturation in the capillary content to be 100%, so it's this number times 1, which is itself added to 0.003 times the P big AO2. So the P big AO2 is equal to the barometric pressure, PB minus 47, times the FiO2 minus the PaCO2 times 1.25. CO2 is 58 times 1.25. And the FiO2 up here, let's say, is 80%. So we're having this patient breathe 80% oxygen, the PO2 is only 55. So barometric pressure 760, that's sea level, minus 47 is 713 times 0.8 minus 58 times 1.25. What's 58 times 1.25?
I can't see the numbers on there. The glare from the sun. That's what I said last week. Oh yeah, you were sitting right here, huh?
58 times 1.25 equals 72. 713 times 0.8 equals 570 minus 72 is P big AO2 of 698. So in our alveoli, we've got a partial pressure of 698 at sea level, breathing 80% oxygen. Okay, so I've done a capillary content and I've done a PaO2. Let's see. Where'd my blue one go? So our C little AO2 is equal to the hemoglobin 14 times 1.34 times our arterial saturation of 90%, 0.9, added to 0.003 times PaO2 of 55.
Yeah.
55 times 0.003 is 0.18 or so. What's 14 times 1.34 is that times 0.9 is 16.8 plus 0.18 is a C little AO2 of 16.98, so almost 17. So our arterial content is 17. This one is, which one? Oh, 14 times 1.34 times 100.
I'm totally on board.
So 698 times 0.003. Whoops.
You said you're lost, so you're just trying.
2.09.
Explain it to me.
2.1. 14 times 1.34. 18.76 times 7. So 18.97 minus 17 and 18.97 minus the CVO2. So CVO2 equal to hemoglobin times 1.34 times, what's the mixed venous saturation? 76. 0.76 added to 0.003 times the PVO2. 31.
I mean,
0.003 times 31 is 0.09. 14 times 1.34 times 0.76 is 14.25. So CVO2 is equal to 14.34.
Bam.
Okay?
Bam.
So really, it's just the content equation.
No problem.
Capillary content,
Like calculus.
It's fine.
arterial content, mixed venous content, and the alveolar air, just to cap it all off.
Holy shit.
If this is like way too in-depth of a question, just don't even answer.
Okay.
But the capillary content, how are we getting that with those blood gas values? Because they're not capillary
It's-
blood gas.
It's the capillary content, where is it? Is the hemoglobin times 1.34.
So it's its own equation that we didn't use.
But it's
those.
still content.
Yeah.
We understand our saturation in the capillary to be 100%.
Oh,
So we
okay.
times it by 1.0, it's by itself. So if you look at the text, it'll show you capillary content, hemoglobin times 1.34,
You know what we should do?
plus the amount dissolved in plasma, 0.003, times the P big AO2, this is the alveolar gas
So those
equation.
4 values that we had to find out are essentially the same equation.
Yes,
Okay.
they are.
Just minor.
Something is clicking in Kate's head, and we're
Capillary
gonna have to
content.
be taught.
Gas.
Nothing was clicking over here, so.
Capillary content minus mixed venous content.
Okay.
So they're all hemoglobin times 1.34 times the saturation, added to 0.003 times either the P big AO2, the P little AO2, or the P mixed venous O2.
Gotcha.
Where do we get that 0.9? 1.34 times 0.9, where did that come from?
90%.
0.003 times the PbO2.
What?
No, the 0.9 above there.
This one right here, 90% saturated.
Okay.
So the arterial content is hemoglobin times 1.34 times the SaO2.
Okay.
And the
Times
SaO2
90.
was 90%.
Cool, cool. I get it. I get it, everyone. We're good.
Okay.
At least somebody does.
So what we end up with then is 18.97 minus arterial content 17 equals 1.97.
Oh, baby.
And then capillary content 18.97 minus 14.34 equals 4.63. So the amount of blood of the 5-liter cardiac output that the heart's pumping out every minute, the amount of blood that goes from the right side of the heart through the lungs, through shunts in the lungs, and back to the left side of the heart to be pumped out through the rest of the body is a value equal to this. Capillary content minus arterial content divided by capillary content minus mixed venous content, and that number
0.42.
1.97 divided by 4.63 is 42.5%. Is that alarming to you?
Yes.
That better be.
I feel alarmed.
That better be. If
Damn.
40% of your blood that's being pumped by the right side of the heart goes through shunted alveoli, in other words, no ventilation, but they're still perfusing closed alveoli. If 42% of your blood's being shunted, we've got to correct that or the patient's going to die. So what's a shunt over 30%? Life-threatening. Here's a shunt of 42%. I've just illustrated by 2 blood gases how that could be. And the physician just looks at you, Truman, and says, can you fix that? Absolutely,
Of course
we can
we
fix
can.
that. We'll fix that with mechanical ventilation and strategies to help to improve oxygen transport. That's how you do it.
How you doing?
Go ahead,
So
son.
like a healthy individual,
Done.
you
Yeah.
have some degree of shunting?
We all do, about
Okay.
less than 5%.
Okay.
Because of the coronary sinus, and because of the Vesian veins, and because of bronchopulmonary anastomosis, we all have a small amount of shunted blood.
So like if we got our ABGs, we put it up there, it'll tell us
Yeah,
when we
We-
put this all in.
we have a small shunt. Because all of our alveoli aren't open all of the time. When we first wake up in the morning, probably posteriorly, or if we sleep on our side, some of the alveoli in the bases of our lungs are closed, but you're still perfusing those alveoli. You get up and you cough a few times and take some deep breaths and stretch, and then your alveoli pop open because of surfactant. So, absolutely. Yeah, you can stretch, just stretch to one side. Take some deep breaths, all the air goes down there. You
Or
stretch
rest
over
toward
this
distance,
side, all
yeah.
that air goes down there.
You've got to do yoga.
Decreases shunting. Okay.
Nice.
So I know that's a hell of an equation to throw at you, but it's really just one equation. It's the content equation.
Yep.
You just put in numbers to reflect the arterial oxygenation, mixed venous oxygenation, and the capillary.
So finding the PaO2 is part of the capillary.
Yeah,
Part of it. Okay. Yeah,
yeah.
the first one.
P big AO2,
Yeah, P big AO2.
alveolar. So the shunt equation is really just a glorified content equation. You just have to know where to
Totally.
punch in the numbers. That's really what it comes down
It's
to.
all gonna work out.
Oh,
So in the end, look at the 4 types of hypoxemia and the definition for cyanosis. It's possible for a patient to be cyanotic and not be hypoxemic. Okay. It just means 5 grams of deoxygenated hemoglobin. So the last question gives you an arterial and a mixed venous blood gas and asks you to provide the percentage of blood being shunted.
Wowza.
I know.
So in this case, we would know that 42% was life-threatening. And a physician may just ask, okay, what are you going to do to correct that 42% shunt?
Bypass.
I'd probably use pressure or PEEP. We'd have to intubate or use probably BiPAP or CPAP, with or without intubation. More often anymore, we're using non-invasive kinds of ventilation first. We're trying to be conservative in our treatment because, you know, it's kind of hard to pull the trigger and intubate a patient right away because of the complications associated with life support. So invasive procedures, you expose patients to risk of, you know, broken teeth, of traumatic intubation or trauma of the upper airway. And then, once the tube's in, they're exposed to ventilator-associated pneumonia, VAP, if you've heard of that term before. VAP is big in hospital complications. And with suctioning, every time you suction, you're exposing a patient to complications, whether or not hypoxemia, cardiac arrhythmias. So it's not a benign procedure to put a patient on life support. But you've probably all seen patients on life support by now. Hannah, next week for sure, dear. So, but the way we make sense of gas transport, and particularly oxygen transport, is in terms of partial pressure, in terms of saturation, and in terms of hemoglobin, the amount of hemoglobin. If we're not making decisions about gaseous transport, or oxygen in particular, on those 3 things, if we're making decisions based upon PO2 alone, it may be an erroneous assumption. So we need to take advantage of all the parameters that we have available to us to make decisions about oxygen transport. And that's really what this chapter does, is it solidifies what we know about oxygen transport. Okay, so the exam through, is it next Friday?
Yeah.
We have
A&P?
2 tests next
We
Friday.
have 2 tests next Friday.
Through next Friday? Okay, I'll make sure that it's open through then. And it's on chapter 5, chapter 15, and just half of 6.
We have patho next Friday too, huh?
Yep. Yep, we
Here
do.
we go.
Patho next Friday. Oh, it's starting. You're putting
Patient's
on our hip.
assessment
We're
right
up to
now.
our hip waders.
Oh, I'm thinking higher than that.
Looking for chest.
Chest.
No, it's more like
Okay.
belly button.
Wait until after we talk about CO2 transport.
No.
So I think I've only got 1 week for CO2 transport, so I wanted to do an overview for the rest of chapter 6.